I work in Bristol, North Somerset South Gloucestershire CCG, so we're a system about 1 million population in and around Bristol. So I head up modelling and analytics in the CCG, and I also hold a visiting position at Bath University School of Management, with whom we do a lot of collaborative work. So first of all, then, why simulate? So simulation is all about constructing a dynamical representation of some real life process and then simulating its behavior over time. So dynamical, we're talking about things over time there, talking about movements, transitions, all of those kind of things over time. And once we have a model, a kind of simulation model set up like this, the possibilities are then endless, really. There's so much we can do with these models. So some examples here, what would happen, you've got an A&E model representing the various processes. What happens if we don't make any change, so do nothing, or if we made a number of different changes, what's the cost, the performance impact, whether it's worthwhile or not. Different things to actually play through in real life. You know, it's very risky to kind of start making changes, potentially, you know, risky changes without in real life. But with a model, if it's decent enough, then you can get a pretty good idea of what the effect could be without actually having to make any actual service intervention. A lot of modelling been done on theatre scheduling to improve efficiencies there. Around COVID-19, simulating admission profiles, given different levels of societal restrictions, different vaccination policies, all of these things which affect then admissions over time. On elective side of things, how long will, so very relevant at the moment, how long would elective patients have to wait under do nothing and do something conditions? And we've got an example a bit later on in this talk around that. So just a little disclaimer as well, right at the top then. So simulation is modelling, and models are pretty much always a simplification of reality. So you need to be very aware of the assumptions that are made in a model and whether those are material, and take that into account alongside any outcomes or recommendations that are made on the back of a model and its outputs. So how discrete event simulation works then? So number of steps here that I kind of think of this in. So and this may not appear clear at first mention, but hopefully it will after a little bit. So firstly, we're performing a number of runs or replications, and each of these simulates the occurrence of discrete events, the sequence as well of discrete events over a given period of time. So we're using, nearly always in discrete event simulation, random numbers to sample from distributions that we know basically underlie these real life processes. So this might be an arrival distribution, a length of stay distribution. We're sampling from those using random numbers. They're not random, they're just draws, they're samples from those distributions selected at random, essentially. For each of those runs, we're deriving some performance measures of the system over time. One run's effectively one way in which events could pan out over a given period. So that could be 1 year, it could be 10 years if you're looking at a real long run, or if you're looking at A&E or something, you know, a bit more quick in terms of the processes, maybe just simulate over a day or a week. The reason we're doing lots of runs is to take account of the variability that occurs, and this is a key kind of asset, but also feature of discrete event simulation, and one that sets it apart really from system dynamics, which unless you do some Monte Carlo or stochastic differential equations at the back end of that, it is deterministic in terms of it's a continuous simulation. It's not really appreciating variability in the way that discrete event simulation is. So we're basically doing those different runs to examine and simulate the different ways that events could play out over a period of time. And then lastly, on the right hand side there, when we've got all of our performance measures for each of those runs, we're then aggregating some costs performance measures with all of those to determining then what the pros and cons of such an intervention or scenario could be. So just to give a little example here of what we mean by discrete events. So say we're simulating, this is one run of a simulation, let's say for an accident emergency department. So we start the simulation at time 0. We're then simulating from our different arrival distributions. Patient 1 arrives to triage, they need some treatment, and then the next discrete event that occurs is a second patient arriving. The third event is the first patient that arrives starting treatment. The fourth event is then that second patient starting treatment, and so on and so on. Different patients arrive, they move forward from triage to assessment to treatment to disposal, etc. And we repeat this, we keep playing forwards these events. This is all happening within some simulation routine that can be coded up in R or simulate via a graphical user interface. This repeats until some termination condition is met. Typically a period of time elapses. So it could be 24 hours for an A&E, or you might be simulating forward years for waiting lists, for example, for elective waiting lists. So this is just one run of a simulation. So we've simulated a number of events according to one way it can pan out in a year or whatever the time period is. Then what we do is we start again right at the beginning, but we change the seeds from which the random numbers are drawn, from which we sample from those distributions. And this is really the backbone of any discrete event simulation approach, whether you're coding it up yourself in R or Python, or whether you're using a package like Simulate or Witness or one of those. Right, so why use discrete event simulation then? Or more to the point, actually, when to use discrete simulation first of all. So when the intricacies of specific events such as arrivals, discharges, treatment completions, etc., those kind of things, or specific measures that derive from those, such as discharge delays, are important. Otherwise, if you're interested more in high-level system flow, you're interested more in if you turn this lever this way or that lever that way, what are the feedback, what are the reverberations of that, then system dynamics is probably more appropriate. So that's looking at higher level whole system flow, for instance, compared to discrete event, which might be looking at the more intricate behavior of a particular service or pathway. Discrete event simulation is often the most conceptually appropriate approach for dynamically modeling things at that level, patient, staff, or pathway behavior, then in terms of those key moving parts, determinants of such things. Often used in demand and capacity modelling, often used for calculating capacity requirements. And the advantages are manyfold over the commonly used and known to be inadequate averages-based methods. So this is, let's say, take average length of stay, take average arrival rate, and calculate some capacity one divided by the other, which is a very straightforward approach. The problem with those kind of approaches is that they don't account for the variability in arrivals and in length of stay, and as well when you're looking over a pathway, all of those discharge delays that inevitably occur at the various handover points. And as a consequence, they can underestimate required capacity significantly, up to 50%, depending on the level, the inherent variability in the system. And this is obviously a big problem if you're then using the outputs of those averages-based methods to calculate capacity requirement, because you will then get queues forming, lots of queues and trolley weights, etc., and all of those effects. So discrete event simulation methods address these issues by providing a more realistic model of the problem. They are in the truest sense a model, not just some very simple formula like average length of stay over average arrival rate or whatever. Okay, so
Rich, sorry, Rich. Yeah. Just a quick question from the audience. How do you determine how many runs should take place?
Good question. Yeah, so it depends essentially on the level of variability in the system. So if you had perfect processes in the sense of no variability whatsoever in arrivals and length of stay, then you only need one run. Then you would actually use your averages-based model because it would be 100% accurate. The more variability you have, the more you need to actually perform runs to appreciate the actual true extent of that variability. So one instance would be if you've got a very fat-tailed distribution for length of stay. So if you've got a heavy tail, a long tail to the distribution for length of stay, you would actually need to perform more runs because you'd want to make sure you've got adequate coverage over the whole of that distribution, including those tail events, which might not happen very often, but when they do, they could cause a big effect in terms of a blockage of a service channel, a bed or whatever, for a very long period of time. So the answer is it depends. There are ways to estimate it. So for instance, you can select one tranche of random numbers, simulate 100 replications, have a look at your aggregate performance measures, then do exactly the same thing but with a different tranche of random numbers, do another 100 replications. Now, when you know you've got enough number of replications done will be the point at which the aggregate performance results of these 100 give you the same results as these 100 here. You've eliminated the simulation error, as we've called it, which arises as a result of not performing sufficient number of runs or replications. Essentially, the results are going to have variability. What you don't want is them to have variability as a result of performing an insufficient number of runs or replications. So it's difficult. I mean, if the trade-off is always, well, perform as many as you can, 1,000, 10,000, a million sometimes, or whatever. But you might have computational constraints in terms of only having a little laptop or whatever. That takes a long time to run a replication. Or constraints in terms of you want to actually get results out now. You can't have them running overnight because you need them for some particular time constrained task. So it really does depend, but more is better if you, as many as you can, basically, within the constraints you've got on time.
Thanks, Rich.
Okay, right, so 3 examples then I'm going to run through today. And I think these provide a good coverage of some different settings, really, which simulation could be applied. So the first one then, looking at a stroke service, this is looking at a whole pathway, and this is looking at events that typically take days and weeks, so admissions within different units and service nodes along that pathway. Then the second one, looking at how we're optimise the processes at mass vaccination centres. That's very different. That's looking at events which happen in terms of seconds and minutes. And then lastly, we're looking at elective waiting list size simulations, and those are events which have typically taken weeks and months, now possibly years as well. So we've got a bit of coverage then over some different applications here. So firstly then, looking at stroke. So the background to this, in Bristol, we've got about a couple of thousand strokes in the system every year. Currently, stroke presentations arrive at any of our 3 acute trusts across our patch. For acute hospitals, at least, for many years, we've been planning to centralise arrival of all strokes to a single hyperacute stroke unit at one of those trusts, where we specialise that very early stroke care that is known to improve outcomes longer term. So this is a significant kind of intervention at within quite a decent pathway in terms of kind of, you know, materiality, beds, resources, etc. The question is, we make this switch, we go, you know, we adjust the pathway in account of this change. How many beds do we need along this new pathway? That's the main question here. What are the capacity requirements of this new pathway? So the current stroke pathway then is at the top. So we've got, as I say, strokes arrive at any of our 3 acute stroke units, our ASUs, and they then progress to their rehab stage after their acute stay, and then onwardly to social care, to discharge, to assess pathways, D2A pathways, and so on. There were 2 proposed options then through our exec board overseeing the stroke centralisation. One was that, well, both of them involved one hyperacute stroke unit, one HASU, and that would centralise all stroke presentations into that unit. But afterwards, the patient might either go to just one acute stroke unit and thereafter to a couple of rehab wards, or they might go to 2 acute stroke units, and the idea would be the acute and the rehab wards would be co-located at those 2 hospitals. So under these 2 pathways then, these proposed pathways, what would be the capacity requirements is essentially our question. So the approach we took was actually we couldn't move the group away from averages based. This was a very well-known method way of doing it. And for setting the allocated capacity, so how much capacity we would allocate to those the HASUs, the ASUs, the rehab units, we went with, or the group went with an averages-based approach. But as we know, as I've said, these are known to underestimate capacity requirements, particularly at peak times. So what we did then was we used discrete event simulation to calculate what amount of flex would be required. So how much would we need to flex into beds adjacent to those hyperacute stroke units, the stroke units, the rehab units, expanding the capacity of the ward temporarily, putting in extra beds to account for the peaks in variability that inevitably will occur. So we kind of coined this phrases of talking about things in terms of allocated capacity, which would be quantified via the averages-based methods, because the group wanted to continue with those. But we said, well, look, yes, but be wary of the extra needs that capacity needs you would require at certain points in time. So then the question was then, okay, so how much flex capacity will we need? How much do we need to be considerate of in terms of the extra resources that at particular times we may need to build into this pathway to ensure fluidity, to ensure flow continues, and we don't get things backing up and then causing problems where a hyperacute stroke unit arrival of a patient with a stroke is unable to access that important resource on time. So we simulated this then. We produced these kind of results here. So we've got our 4 different users. This is the option 1, by the way, with 1 ASU. So we've got HASU top left, ASU top right, and then the 2 rehab units at the bottom. And what these outputs, these are fairly standard outputs with discrete event simulation. So this has given you a probability distribution, a density function of the or mass function in this case, of bed occupancy. So the dashed vertical lines in each of these is the allocated capacity using the averages based method. So what we're doing here is we're working out what percentage of the time does the bed occupancy spill over that number of beds that has been allocated. So for instance, here we said 22 beds would be allocated to the HASU, and there was about 22 for the ASU as well. And as you can see there, 30 for the rehab 1 and 12 for the rehab 2. We were looking here at how much extra flex do we need to build into these pathways. So example on the top right there, that mass of all of that probability to the right hand side of that dashed line accounts for 20% of the time. So we're saying 1 in 5 days essentially we'll need to actually reach into some additional capacity for the acute stroke unit if you set your allocated capacity at 22 beds. Hopefully that makes sense. So as I say, you read the graphs basically as probability mass, so you're reading across the number of beds occupied, the bed occupancy on the x-axis, and then what the y-axis is telling you is the percentage of time the system spends essentially with such numbers of beds occupied. Okay, so we're looking at then the masses at those various different points of most interest, what's to the left and the right hand side of the dashed line. So as I said, these showed the proportion of time the HASU and rehab units spend at different bed occupancies. Anything to right of the dashed vertical line represents use of flex capacity. So summarising these results then, we're looking at option 1 here and option 2. So you can see there the difference between these being the extra row on option 2 to include the ASU 1 and ASU 2. We've got then our allocated capacity, 22 beds, 22, 30, 12, etc. And the model outputs are those last 4 columns on the right then. So this is telling us our mean total occupancy, so our average occupancy over time. But it's also telling us the time within the allocated capacity, the mean flex required, which is basically how many beds on average do we need additional to the allocated beds, and the time at the full allocated and flex capacity limits. So essentially this is giving an idea of what is going to be our average bed occupancy, how much are we going to actually need to put additional beds in those units, and staff, etc. as well, to account for those peaks that inevitably occur, given we've got a highly variable system here. So particular learnings, so it's, for one, the whole idea of thinking about things in allocated and flex was new to us. Subconsciously it happens, you think, this is an allocated amount of capacity and this is essentially what we may need to expand to temporarily, but assigning it clearly was a particular learning. Also interesting, you can't quite, well, yeah, you can quite see it here. There's economies of scale, so pooling the ASUs require less overall ASU capacity, so subject to the same performance of the system in terms of blockages and waiting times, etc. So this is economies of scale. Essentially, the more you break up and subdivide things over lots of different hospitals, the more ultimately total capacity you're going to need in order to stop those units, those smaller units, filling up and then having waits and blockages and delayed transfers of care and so on. Outcomes then, so the model flex capacity requirements were included within the centralisation plan. This ensured sufficient capacity available at the peak times. As I say, fluidity, meaning minimising the chance of HASU capacity breach. We were looking at about a 1 in 100 chance of a HASU capacity breach, which was determined to be within tolerance. All of this went into our outline business case, which was independently reviewed by the South West Clinical Senate, who were very positive in terms of the demand and capacity modelling we did here via simulation. The final business case got approved a couple of months ago following public consultation, and we're now awaiting the kind of go live of the centralised pathway later this year. The second case study, then, I'm just seeing what I'm doing for time. Okay.
Can we pause there for a couple of questions we have in chat? So we got the first question from William. How did you determine the granularity of the model to be used? What was the model structure? Sorry, was the model structure as shown in the flow charts? Yeah,
absolutely it was. Yeah, so I'll just talk a bit about what are the key things then in a simulation model here, and this relates to the data. So the key parameters we're looking at here are the arrival rates. So what's coming in here, the external arrival rates, I often call it. So this is a node-to-node arrival rate. You know, we don't need to estimate this. This will just be implicit. What we're talking about here is what's coming in. What's the actual the arrival rates coming into this system. So that's one parameter. So you need to estimate. You need to have the data to then support parameterizing that variable there, the arrival rate. Then you're looking at length of stay and capacity for each of the nodes. So here we, for the acute stroke unit and the rehab, certainly we're able to look at historical data, because this wouldn't be too affected by the change the further you go down in the pathway. So you fit distributions to the data for length of stay here. For HASUs, we don't have a HASU currently in the system, or at least not at the time of the modelling. We had to rely upon literature. So we went into the published literature and found how long Manchester and London patients were spending in their HASUs, and basically formed a distribution around that. But typically you go into your data and you'll fit distributions to the data you've got for length of stays. So it's arrivals, one parameter. Second, it's the length of stays of each of the service nodes you're modelling. Then third is the capacities of the service nodes that you're modelling. So in this case, we were looking at whatever the bed limits were for the HASU, for the acute stroke units, for the rehab wards. You can look at that on a do nothing and a do something basis, so you can play around with those capacities, of course, and look at the performance measures. And the fourth thing is the transition rates. So what, for instance, here, I don't know whether you can see my mouse, but in this B diagram here, you'll see that the acute stroke unit branches off. So patients who pass through the acute stroke unit, some go to rehab 1, some go to rehab 2. So you need to tell the model what proportion go to rehab 1, what proportion go to rehab 2, and you would, you'd mine your data. You'd look at your data to inform then that parameter in terms of what proportion you send each way along the pathway.
Rich, we have a few more questions, and I wonder whether it's worth coming back to this example at the end and cover the specific questions people have. Conscious you have 2 other examples to go through, so if people are right with that, I think that might be a sensible approach.
Sure. But
you're generating a lot of interest in understanding the details of how you've done this, but which is a good sign.
Okay, all right, I'll carry on then. So secondly then, mass vaccination centre. So the background here, exercise Panacea took place 2nd of December 2020, so just over a year ago, at Bristol's Ashton Gate Stadium, a big football rugby stadium in the city of Bristol. So this exercise, which was in the local press with Army, the RAF coming in to help run. This was only the second live exercise to dry run a COVID-19 mass vaccination centre. So this was a goldmine of information. You know, would be simulating arrivals, people coming in. We had people from the health service, volunteers who were picking up scripts which said you're an old person. You walk slowly from, you know, assessment to vaccination, etc. You're hard of hearing. You ask the question again. The idea was to try and simulate in real life actually how the configuration of this mass vaccination centre could play out in order to fine-tune the kind of operational configuration ahead of going live. And it would be going live literally only a month later, literally 4 weeks later, we opened to the public. So I went along with my stopwatch and clipboard and started timing how long people would spend going through those different service points, which I'll explain a little bit, those service activities, which I'll explain a little bit in a second. Essentially, though, the key thing we were initially interested in is around daily booking numbers. So how many should we book into this site? Now, if we book too many, then unmanageable queues will form, will compromise social distancing, we'll get bad press in terms of patients waiting hours and hours at the Ashton Gate Centre, etc. That may dissuade others from wanting to turn up for their vaccination. On the other hand, if the bookings are too low, then we're wasting vaccine and human resources in that centre. So as I say, time was tight. Our team attended the exercise to observe and source the necessary data. And our aim then was to actually, they were doing a real life simulation. We would do a computer simulation based on the data we gathered from that real life simulation. And we would use that to actually inform service delivery ahead of it going live. So this was how it looked like. Basically, this isn't that different from other, in terms of the overall flow from other mass vaccination centres. So essentially 4 activities: registration, then clinical assessment, then vaccination, and then observation, depending on the vaccine administered. And at the various points here would have queues. So patients would queue for registration, then they'd queue for clinical assessment, queue for vaccination, and so on. Site management originally proposed that 1,500 people could be vaccinated on each day, so the site capacity was 1,500. What we did then, and the previous question there actually highlights some of this then, is around the data, fitting distributions to the data. So in a lot of discrete event simulations, if you go to Simulate or SimPy or whatever it is, you'd be asked to tell the simulation around length of stays what distribution for it to use. So what we did here, we fitted a number of different parametric distributions to data that we collected on the day, so from the live exercise, and we found really good fits actually. So the kind of PP plots on the bottom there, and kind of CDF plots there, showing the actual data versus the fitted distribution. So good alignment. So we were able to actually approximate the processing times for registration, clinical assessment, and vaccination using those distributions that we put into the model. So just to say here, like the median length of stay for registration there, so you're looking across on the y-axis 0.5, you're reading down, is about 55 seconds, I believe it was, so about a minute there for registration. That's how long people took. Clinical assessment longer, we're looking at 200 seconds, what's that, just over 3 minutes, and about the same for vaccination. So that's on average how much it took for the 3 different activities here, although there's of course variability, and that's exactly what these distributions show here and why we're modelling it in this way. So we used we simulated this then based on those inputs. We actually here flexed the arrival rate, and we were looking at basically a tolerance on performance measures like waiting time and queue size. And by doing so, we found then that the actual maximum daily throughput of the site was about 1,250, so a fair bit less than what was originally proposed. And site management accepted this and went with this as the number of bookings of vaccinees for at least the opening few weeks, couple of months or so of the site before there's some other service changes. And this averted potentially severe consequences we looked at. We actually modelled through with 1,500, finding that we would get significant queues forming if that had happened. We had the Prime visiting the Ashton Gate site within the opening week as well. So, you know, we that would have looked very bad if there'd been queues going out the door. So we affected kind of things in that way. We also had another couple of recommendations, one which was to, based on looking at the size of the queues and the distribution of the queue size, was that there was insufficient queuing space. If I go back here, you'll see that there was only 15 spaces for queuing before vaccination. Now, what we actually found through the modelling was that that wasn't enough space, that actually when we modelled this through and we looked at the probability distribution density functions, those same plots as for the stroke example, but for the queue size here, that would exceed that 15 on the x-axis a not insignificant amount of time. So we recommended increasing that queue space there at the expense of reducing the observation space. We found in the modelling that you didn't need 64 seats, much less than that was required. So we had spatial limitations on the site. So we said, get rid of a few seats, move the vaccination pods along, and increase the queuing capacity you've got ahead of the vaccination. And that was heeded as well, our advice there. We also looked at shocks as well. So one of the, as I mentioned at the start, the useful things of a simulation model is that you can play through things that you just can't play through or wouldn't want to play through in real life. So what we did here was actually just, we said all of these arrivals that we're saying occur per hour, let's say that through, let's say there was a big traffic problem or something like that, and half of those that were meant to arrive in the second operating hour of the day actually arrived in the third. So what we see here is basically the effect of that shock in terms of here, we've got the queue size here for the essentially the combined assessment and vaccination pod. See this massively increase if you just have a deluge of patients all occurring at once. So this was a shock we want to build robustness to kind of address, essentially. So so we looked at these kind of what if type scenario analysis questions to try and get an idea of how robust the setup was. I'll just mention here that both for the stroke centralisation and the MassVax project, we didn't use simulate or code from scratch simulation. We actually used some software we developed a couple of years ago, funded by the Health Foundation, which is a versatile simulation tool for demand and capacity modelling on pathways. This is coded in R, and it uses R Shiny as a front end, and we call this PathSimR, and it's freely available at our GitHub link there. I was going to go on to the third one. Edwin, are you happy for me to go on to the third one, or?
Yeah, there's a very quick question on this example. We can quickly cover that one. Just for your length of stay distributions, did you create your own distribution based on actuals or try to fit these to an existing distribution?
Yeah, so so often I kind of alluded to this, but just a bit more info then. So what you see here, the black line in these top graphs is the empirical CDF. So that's basically what the data is telling us is our distribution, our cumulative distribution function.
Oh, actually, that was apologies. That was the previous example. Sorry, Joe.
Okay.
So you can move on, and we will try to come back to that previous example, which has quite a few questions. So apologies for not covering those. I thought it was a quick one for this one. Apologies, Joe.
Okay. Well,
okay,
I'll mention it now because this is actually I'll mention it quickly now. Essentially, what we're doing, a lot of simulation software doesn't allow you to put in empirical CDFs. So you might have empirical data. The best thing to do with it is fit distributions to it and try and select the most best fitting probability distribution. So like two parameter choices are log normal, Weibull, gamma, for instance. Those ones are all right skewed distributions that are good for length of stay. So essentially, yeah, you fit those, and then all you need to tell the simulation program there as inputs is what distribution type it is and what are the parameters of it. So For instance, if it's a normal distribution, it's the mean and the standard deviation, the mu and the sigma. If it's the Poisson distribution for representing arrivals, then it's lambda, which is the average rate over time. So basically, those are the key inputs typically to a simulation model. You don't provide the empirical CDF or the empirical distributions. You fit on the empirical distributions a parametric distribution. It's not that difficult. There's tons of stuff out there which allow you to fit all sorts of distributions to this and just estimate the parameters. Often the log normal is the best one. That's what you're seeing here, but featured in a lot of our other modelling as well. So then thirdly, then elective waiting list size and waiting times. So so basically the 5 key ingredients, at least as I don't think of it, of an RTT pathway is clock starts, clock stops, capacity, performance and waiting list size. And I'm certainly not the first to use the bathtub analogy here for bringing all 5 of those into focus. Essentially what we've got the tap, which is our clock starts, those are our referrals. Our diameter, if you like, our size of the plug hole essentially is the capacity, and through that passes the water, which is our clock stops, our activity. The waiting list size is the numbers of incomplete pathways. And I think actually what I probably was first to do is actually in this analogy bring in performance, which if we imagine that the water coming in is hot here, the performance is essentially the temperature. So the slower the throughput or essentially the slower the water is going through here, the longer they're waiting, the cooler that water is going to get. I mean, I'm not going to go through the example here, but basically through this analogy, you can actually prove without even modelling, not prove, but you can actually work out what the effects of any kind of changes to some of those variables would be. As I say, without even having to model it, you can just think through it logically, and you'll find some kind of understanding there. But we can model it. We have modelled it already. A couple of papers here that I've published on this. The left-hand side one was looking at the overarching dynamics of RTT in the NHS, basically modelling that bathtub as you saw it. On the right-hand side, I applied that exact same model to elective waiting times and possible impacts on elective waiting times at the beginning of the pandemic, when trusts were asked to postpone all non-urgent elective treatments for at least 3 months. So I played through their various scenarios on what effect that could be on RTT performance in terms of the 18-week target, waiting list size, if demand and capacity are 2 levers, the referrals and the capacities were flexed to some certain levels. So what's happened in recent months? This is at a national level. We've seen, after a little decline there, the waiting lists rise and rise at a rate far greater than the rate we saw pre-pandemic. That period being the dashed grey line. That's 12th of March 2020, when it was declared a pandemic. RTT performance was on the whole dropping already in the years before things, but it's taken a much greater drop and now seems to have stabilised around late 60% region. And the number waiting over 52 weeks, well, this increased about 300-fold from before the pandemic to its peak in July 2021. So is there a 6th ingredient we need to take account of here? So the expectation is that actually, through our analogy, we can build in water flowing over the top of the bathtub. So this is reneging. This is essentially, in queuing theory parlance, say a feature where the waiting times get too long, and rather than waiting for service and the queue growing and growing and growing infinitely large, people react and go somewhere else through their own volition or otherwise. You know, in our case here, in waiting times, they could be going private, as we know has happened an awful lot recently in response to waiting times, learn to live with the condition, becoming inoperable or even dying. So we can model this, and we've done this. We've adapted our model to account for reneging. Actually, we've done this in a discrete time simulation, not discrete event simulation, but it's pretty much the same thing. Here, we're not looping over events. So what we've got here is the outer loop, which is the runs. So this is our replications here. We've got, what's that, 100,000 runs. We're saying, again, this is our, instead of looping over events within the inner loop, we're actually looping over time steps. So in a discrete event simulation, you have a big loop, which is looping over all replications, and then each replication would start at time 0 or whatever, and then it would be looping over events. So what's the next event? Update the system. What's the next event? Keep on going until you reach a certain cutoff of time. In a discrete time simulation, exactly the same, but instead of looping over events in the inner loop, you're looping over time steps. And then you're looking at the number of events that occur within each time step. So it's still kind of discrete event, but it's time driven. So here are two main events, of clock starts and clock stops, and on the basis of which arrivals are happen and which order they're served, we can then calculate performance measures, the waiting list size, and we can look at any point in time at the end of a time step, what is the proportion of those waiting under 18 weeks or under 52 weeks of those that are on the waiting list. And we save these measures down, and we keep doing that for each replication, and at the end we aggregate across all of the metrics, and then we get nice variability as well as average results as well. So we've applied this to all or using publicly available data to basically the whole England position. So we've got our waiting list there where we started. Our initial condition there was around 6.7 of 6 million, I think it was 5.8 million. And what we did here is we looked at we flexed two things. First of all, referrals. We assumed the pre-pandemic rate of referral growth, and what we did, we played in different amounts of the 7 million estimated missed referrals during the pandemic to return. So this is 0% of the missed referrals returning in the next 12 months, 25%, 50%, 75%. We also then flexed capacity, so we're looking at 100% of pre-pandemic capacity in year 2019-20, as well as 10% more and 10% less. So you can see here then the effect of flexing these levers on the waiting list size, which is the top panels, the 18-week RTT performance, which is the middle panels, and the numbers waiting over 52 weeks, which is the lower panels there. And as I say, one of the advantages of simulation is about all of this variability. And when you look at all of the 1,000 or 10,000 replications, you can calculate the average, which is the solid lines in each of those cases. But you can also calculate the confidence bands as well. So this gives you an estimate of confidence. You can't do this in an averages-based model. You just get one result. Even in, correct me if I'm wrong, Vanessa, even in system dynamics, you won't get a variation of outputs because you're not implicitly accounting for variability in that approach. That approach has other benefits that discrete event simulation doesn't have, however.
The way, sorry, Rich, to try to answer your question, the way system dynamics package are compensating that out is with a sensitivity analysis. Mm-hmm. So you identify a number of variables that you would like to test the sensitivity to, and then you run that sensitivity analysis and give you something that looks quite similar to what you're getting here.
Indeed, yeah, no, absolutely, yeah. So there's yeah, indeed. I mean that sensitivity analysis, you'd be flexing the scenarios, and that can give you one source of variability. Here you're playing through the actual inherent variability in the system itself. So there's just be mindful that we're talking about there are different types sources of variabilities, if you like, between the different approaches, both of which hold their pros and cons. Implications of this then, I mean I won't dwell on this too long, but I mean some of the weights here that can be projected are pretty long, so the kind of questions are, these are things that we're looking at the moment, not via simulation, but what are the additional resources that patients will consume whilst waiting, because we need to quantify this. So if we've got a load more patients waiting a load more time, then we need to work out how much extra activity they're consuming just by virtue of being on the waiting list. And is this a false economy in terms of whether we should keep them waiting or just invest up front more in elective capacity, so we avoid all of that longer term failure demand, essentially. Anyway, I'm not going to dwell on these things, but those are kind of things that can be derived in terms of insights from these simulation outputs. Just wrapping up then, just to say simulation is not always the answer. So if we take this waiting list forecast model, so what I've said here is, yes, this is a fairly sophisticated model, fairly appropriately aligned to what is actually a fairly complex problem. But the more sophisticated we get, the more parameters there are, and the more data requirements there are. More parameters means more data to estimate each of them, and the more computational time we have in terms of running this. So it gets very complicated. And and this has meant that we actually can't run this simulation model at all of the granularities that we'd like to, because it's just too much time and effort. So sometimes actually simpler analytical models are the answer, and this is strange just outside simulation at the moment, but just to give you an idea, expressed a different way, we've essentially, this is our problem. We've got a waiting list, we've got referrals, and we've got treatments, and we've got ROT, which is the Renegs, which is a function of time, waiting time. And this can be expressed actually as a differential equation, which is, and solved. The solution is basically this. This is actually a simpler model than the simulation, but this is a hell of a lot easier to solve and get projections than it is to simulate quite a complex setup. And from that, we've managed to scale this up. So we can actually get, for every trust and specialty in England, a projection of waiting lists and waiting times under different assumptions. So here we've looked at 0% referral growth annually, 1% and 5%, and annual treatment capacity growth of 0, 5 and 10%. So an example for one of our local trusts here, basically this is our time now, the dashed black line, we're looking at different specialties here, and the different lines there are different projections accounted for the different referral growths and capacity growths. And we can do this for waiting times as well. So here we're looking at the average waiting time for these given specialties under these different assumptions here into the future, long term, for the next like 3-4 years. And if you go on our GitHub, you can actually find in there, because we did this last week, scale this up over every trust and specialty in England. So you can go into our public GitHub, and the link's just there actually, and find your trust and specialty and obtain these forecasts here. There's no guarantee of this. This is just something we've done. We put out there. If there's any feedback, ways to make it better, assumptions or whatever that you're not sure of, let us know. That I thought it might be interesting to some people. Just to summarise, then, simulation, an important, useful tool for addressing operational and strategic dynamical problems. In many ways, the NHS is just a sequence, a system of many interconnected queues, and with simulation, we're often looking at queues and dynamical flow. So it's very conceptually appropriate. However, it's not always the most the most appropriate choice. So system dynamics may be more suitable, or even agent-based simulation, or, as I was just saying, a more simple mathematical approximation, which is a bit more basic and not as extravagant as otherwise.